recording. Good morning, everyone. A very warm welcome to this session today. And our speaker for today is Dr. Kanika Naug, who is a rehabilitation consultant at APM Work Care, New Zealand. Dr. Kanika Naug has her master's and doctoral degree from the University of Delhi and a PG certification in rehabilitation from the University of Otago, New Zealand. Dr. Naug has taught in Indraprasth College, Delhi University for 21 years and has established the Department of Family and Child Welfare. Her work in New Zealand involved working with school-leaving children with disabilities, disabled people and employment, and early childhood education. She's currently working as a rehabilitation consultant with both pediatric and adult clients. Her pediatric work involves working in a multidisciplinary team of physiotherapists, occupational therapists, and speech-language therapists. As a team, she's involved in planning and implementing therapy goals to support children towards achieving their developmental milestones and school readiness. She works in school settings and daycare settings. Welcome, Dr. Kanika Naug, to this session, and thank you for accepting our invitation. I now request our principal, Professor Swati Pal, to formally welcome Dr. Kanika Naug to this session. Thank you, Professor Pal.
Well, good morning again, everybody on this forum, and a very, very warm welcome to you, Dr. Naug, for joining us and for consenting to speak to us. It's a really cold, wintry morning here in New Delhi. I don't know what it's like in Wellington, but here it is really cold. However, I think that the kind of conversation that we're going to have today is something that is going to warm our souls, because it deals with an area that is very close to our hearts. The whole idea of disability and the fact that we sometimes don't know how to deal with it, probably because we are not well informed about it. And I don't think enough is done by all of us as academics to really make it an inclusive subject. However, I am given to understand that disability studies across the world now are really progressing. I know that Delhi University too is focusing on its Disability Studies Center. And that is a very, very positive sign, because it shows a society that is more sensitive to the needs of people who have been otherwise very marginalized. When I say that, I include geriatrics, I include disabled people, a whole plethora of people who often get left out or who get stereotyped, So today's, I think, topic is very, very relevant, and I'm not the person who should be speaking. I'm here simply to welcome you, Dr. Naug, and it is so wonderful to know that you are well, I don't know if you're an alumni of Delhi University, but that you have taught at Delhi University for 20 years, and you told us that you were part of the team for whom the HTFE was like a baby. Well, your baby is now a grown-up child and is really kicking well, as you can see from the fact that we are holding this international webinar. So warm welcome to you, and looking forward to listening to you. Thank you. Thank you, Nami. Thank you once again for organizing this and for bringing Dr. Kanika to us.
Thank you, Professor Pal, for your kind words and for your guidance and motivation. And yes, Kanika is an alumni of Delhi University. She also studied at Lady Irwin College. Very warm welcome, Kanika, and it's so lovely to see you here with us today. I wish we were in the physical mode, but all the same, a very, very warm welcome, and the floor is yours. Thank you so much.
Thank you so much, Professor Paul, for welcoming me. And it is summer here, so it's really hot today. And for us, hot means today is like 25 degrees. So it is really hot. And it is really a pleasure for me to speak to the students of HDFC. And as I said, Nimi and I were part of the group that established HDFC in University of Delhi. So really, I'm pleased to be here, and I think we should start. So if you can put on the slide 1, we will start. Awesome. Thank you so much. So today's topic, dear friends, is children with special needs and a multidisciplinary approach to support the developmental goals. As Nimi said, that I do work as a rehab consultant, both in pediatrics and with adults. And I work in a range of settings for children with special needs. It is clinics, it is homes, it's schools, preschools, and also in the community. So the next slide, please. Thank you. So before we launch onto what is multidisciplinary approach for children with special needs, or how we support children to achieve their developmental goals, let's kind of do a quick overview of who do we consider as children with special needs. And as Professor Paul mentioned in the welcome, that we are actually becoming more and more inclusive society, and that is huge all over the world. And I'm sure even in India, the society itself is becoming more inclusive, and we would look into how we, all of us, can support and bring our expertise, our specialization to help children reach their full potential. So when we talk about children with special needs, these are, as you can see on the slide, the areas that we talk about are developmental delays. So it could be delays of milestones for the child to sit, walk, crawl, or feed itself. So those are the developmental delays that we are talking about. Hearing impairment. So that could be from mild hearing impairment to profound hearing impairment, which is deafness. Vision impairment, that again can be from very mild to profound. Cerebral palsy, neurological conditions, there are a range of it. Brain injury. Now, brain injury can actually cause the few of the above categories, like developmental delays, hearing impairment, vision impairment. In fact, I work with a lot of children who have had experienced brain injury. The other categories are childhood apraxia, language-based learning difficulties. Again, important for us to know. And I'm kind of guessing that all of you are students of child development, so you do understand language, learning, cognition, etc. So learning difficulties are a lot of time language-based, and learning difficulties caused by language delays or language difficulties can have impact on the other spheres of development for any child. Then some common syndromes such as Down syndrome, hypersensitivity syndrome, genetic and metabolic syndromes, ADHD, which is attention deficit and hyperactivity disorder, and ASD, which is autism spectrum disorder. So these kind of covers more or less all the different categories children with special needs will fall under. But of course, this is not an exclusive category. Next slide, please. Thank you. So in today's webinar, we are talking about a multidisciplinary approach. So basically, as we talk about what multidisciplinary approach is, who are all there, that is, who are the professionals who form the part of the multidisciplinary team, we will touch upon what each specialist or a professional does in the team. That will kind of give you a picture of how different professions or different professionals are supporting the developmental goals for a child with special needs. So I will talk about the multidisciplinary team approach, and we call it here MDT approach. So you will see me reverting back to that word MDT again and again, because that's part of my vocab. So it means multidisciplinary team approach. So The basic premise of the multidisciplinary approach is what you study in as a part of child development theory is that the physical, cognitive, emotional, and the social development, all the spheres, all the aspects, all the areas of development are interwoven, they're integrated, they interact with each other and have a kind of a integrated or combined effect or impact on a child's development. So none of the development actually works in a silo or they are not compartmentalized. And hence the multidisciplinary team approach, so that the number of professionals with their specific expertise or specialization are able to be part of a team to support range of needs or developmental goals of a child. So how we go about in this team approach or in this kind of therapy approach is that once it is determined that a child has special need and is eligible for individualized early intervention, and we all understand the importance of early intervention and how much it can have an impact on the child or how much it can support a child. So once it is determined that a child would benefit from early intervention or special education services, the multidisciplinary team will get together, will write a plan, outline the service, that is, what is the service going to be like. And this plan will outline the individualized goals as per the evaluation or assessment results of for the child. And also will take into account parental concerns, parental goals. And what we call an IEP is formed, that is an individualized education program is formed or, put together. So again, individualized education program, although we are talking about, we have, ideas about developmental norms, what should happen at what age. But again, the basic premise of child development is also to understand the individual differences. So therefore, any plan, any therapy, any support that you are going to do for or provide a child has to be individualized, is based on the child's specific needs, and it is not a kind of a one size fits all. So that's what children with disabilities will have a range of needs, variety of needs. Each child differs from the others, and therefore they will require expertise of a number of professionals. Next slide, please. So before I go into who are the people in the multidisciplinary team approach, we will just kind of quickly look into what kind of needs we support or the multidisciplinary team would support. So what are the general support needs for a child that would help the child to reach to his or her own full potential and also be able to address the developmental goals for that particular child. So the specific areas are fine and gross motor difficulties, delayed play, developmental delays, again, like milestones, delayed milestones, sensory processing, neurological delays, learning difficulties, attention difficulties, emotional regulations, sleep difficulties, personal cares, independent living skills, social skills, and mental health. So these are the general areas that a child would need support from the professionals, but that does not mean that each child will need support in all these areas. It would be very, very specific to a child. But these are the general areas where we would be, or a team would be supporting a child to reach or achieve their developmental goals. Next slide, please. Thank you. So now we talk about what consists of a multidisciplinary team. It is also called interdisciplinary sometimes, but we generally, or I use the word multidisciplinary team approach, and that's the kind of team I work in. So the topmost or the most important or the core person in a multidisciplinary team is the parents or caregivers. Why I say caregivers is because there are a lot of children who are not brought up by their biological parents. It could be a close relative, it could be a grandmother, grandfather, or it could be anybody else who is the immediate caregiver for the child. So the parent or the caregiver form the core of the team because they are the most important people or persons in a child's lives. And they are the people who will have their own concerns and own goals for their children. And they, as we say in child development, our parents know the best. They can be supported by the professionals, but a parent knows the child the best. Then we have occupational therapists, physiotherapists, child development coaches, speech language therapist, psychologist, dietitian, nurse. And this team, that is this multidisciplinary team, generally works in collaboration with a wider child development team, which would have health professionals such as pediatricians, neurologists, GPs, which is the general practitioners or doctors. So those would be the people that the multidisciplinary team would be collaborating with or working alongside, but they are not actually part of the team. They are the kind of people who would be consulted from time to time for advice for any concerns, etc. But people who are working with the children at a given time are the ones above. Next slide, please. Thank you. So what is the process or the steps that we have in a multidisciplinary team approach? That is, how do we go about it? So of course, the first step is the diagnosis. That is, a child needs to have a diagnosis before special education or a multidisciplinary therapy is planned for a child. So there has to be a diagnosis about what are the developmental needs or the special needs of the child. And this diagnosis is followed by an assessment, excuse me, assessment and evaluation, which uses standardized assessment tools. And there are a huge range of standardized assessment tools. And that's a whole different webinar for another day, or you would be doing it in your coursework possibly. Then the next step is to take a parent-centered approach and a collaboration to develop therapy goals. I think we missed that. Okay, cool. So a parent-centered approach is taken, that is, before we sit and formulate goals for or do a plan for a child, the parent is part of that planning. That is, what are we looking into, what kind of needs we are addressing, what kind of developmental goals we are supporting. So a parent-centered approach and a collaborative approach between all team members is done to develop a therapy goals for a particular child. Then the therapy plan or goals are developed as per recommendation and assessment. So it's not out of thin air, we'll make a plan. We will see what recommendations have come following the assessment, following the diagnosis. So based on that and based on the knowledge of child's developmental needs or pathway, we would form a plan. Then the therapy goals can be both short-term and long-term. So some goals will be short-term, some goals would be long-term. For example, if we are thinking that a child would be supported to complete self-care needs in the morning, like get ready for school in the morning or for the preschool in the morning. So the short-term goal would be there that by 3 months, the child would be able to put the dress himself or would be able to complete the toileting or brushing the teeth by himself or herself. So that could be a short-term goal. And the long-term goal could be by the end of the year, depends, of course, it can be scaled up, scaled down, depending on how the child is progressing. The long-term goal can be adjusted. So we break a goal, a specific goal, into a short-term and long-term. That is long-term, this is what we are trying to achieve. And what are the steps that are going to take us to that long-term goal? So those are the short-term goals. Then the therapy goals are implemented at clinics, home setting, school, daycare, and community settings. Some of you might be wondering what community settings we are talking. Now here in New Zealand context, the community setting could be swimming pool, could be the park, or could be any other place that the child would be going, like going to the library for story session, because again, the child's development doesn't take place in vacuum or in silo. Child is going to go into all these settings, and we need to kind of support the child to be as functional in all these settings. So therefore, the therapy has to be also setting specific sometimes. And also sometimes we talk about community and home, because schools and daycare, they are not running 12 months a year. So the therapy doesn't stop. So when the schools or the daycares are closed, other settings can be used to implement therapy goals. Then periodic evaluation of goals. So periodically we'll evaluate goals, how the child is progressing. So again, there is a collaborative approach. We'll meet periodically to kind of have a discussion on how the child is progressing, what needs to be added, what has been achieved. And then, of course, the joint sessions are done, wherein team members from different disciplines will work together to support developmental goals. So individually, also team members would work with the child, but sometimes we do joint session, because again, thinking that all areas of development is taking place simultaneously. They are not like cognitive development today and motor development tomorrow. So it's happening same time for the child. So there are a lot of time one would do joint sessions where, say, a physiotherapist or a child development coach would be working together. So these are some of the basic, process or steps involved in a multidisciplinary team approach. So next, what we'll do is that I'll go through the role of all the different kind of team members in a multidisciplinary team, what they do, how they support the child, and that would give you an idea of how the developmental goals are being supported. Next slide, please. So the first one is child development coaches. Now, this is pretty much a random order of the people in a multidisciplinary team. So there is no hierarchy that this comes first and the other team member comes next. Or so there's no hierarchy. It is just pretty much random. It is how I've done the slides. So it is nothing like that this particular team member is more important than the others. So it is more or less whatever way I done the slides. So the first one, we are talking about child development coaches. So the child development coaches could be people with a background in early childhood, child development, also psychology sometimes, so a variety of people. I actually work as child development coach or a rehab coach. So child development coaches are sometimes the key service coordinators. That is, they are the ones who are coordinating other team members. Also is the link between the team, the parent, and also team, the school. Could be doctors, could be other people. So sometimes, not always, a physio could be key service coordinator as well. So most often, a child development coach would be a key service coordinator. So what would a child development coach do with children? So they will implement therapy plans. So the therapy plan is done, that these are our plans, these are our goals, this is how we are supporting the child to achieve their specific developmental goals, whether it's gross motor, fine motor, reading, writing, learning, whatever. So according to the plan, the child development coach would implement therapy plans, again in a range of settings like clinic, often see children in the clinic, school, daycare center, community, and home, as I said. Child development coaches will also support children to achieve their fine motor and gross motor skills, so activities which are related to help child gain fine motor and gross motor skills. Hand skills such as pencil use, scissor use, pre-writing. So pre-writing is generally coloring, drawing, etc., and maybe threading beads, etc. So these are all which kind of helps child get the pincer grasp, that is able to hold a pen or something finer with the finger and the opposing thumb and the opposing finger. Coloring, doing buttons, use of spoon, fork, that is the child is then able to feed himself or herself. Independent self-help skills, for example, feeding, dressing, bathing, hair combing, and hygiene, which is toileting needs, being able to be toilet trained, etc. So these are the goals that the child development coach would be implementing at home with the parents, with the family, at a school or a daycare. Then sensory regulation activities, that is how to regulate the stimulus that a body gets from the environment and from the stimulus. So a lot of children with special needs have difficulties with sensory regulation, and we'll talk about it a bit later. Play skills, and then also transition support between preschool and school. So some of the therapy goals or some of the plan goals would be making the child ready for school. So school readiness sometimes is a goal, a developmental goal for children, because as you know, in preschool, children get more one-on-one kind of, you know, care or attention, whereas in school, you do not get that. I'm not too sure what is the ratio of children versus teacher in India at the moment, whereas preschool, as far as preschools go. But here it is 1:5 or 1:6 max. So one teacher for 6 children. So that is preschool. But when the children go to school, they need to look after themselves. They need to eat their own lunch, find their own classroom, find different other things that's happening, have some organizational skills, etc. So school readiness is a huge thing that our team would support children with special needs. And it's also about being more independent and able to, and sometimes children with special needs would have teacher aides or support workers, but still it is a different ballgame altogether, school and parental support. So basically, whatever we are doing with a child or with the children that we are working with, the parental support is to understand what's going on, how the child is progressing, what is happening, why we are doing this activity, how that supports, what they can do, for example. Next slide, please. Thank you. So this is an example that I put in that that we often do this, like make a routine, a chart for a child. You can think about this as doing it with the children that you work with in some other activities that you might be focusing on, or even for a group of children. So this is a bedtime routine for a child. So go toilet, take a bath. Now this is a little bit of explanation I'll give here. Taking a bath is a bedtime routine here in New Zealand and most Western countries. I don't know why. Maybe because these are cold countries or has longer winter time. So children generally are given a bath before they go to bed. So it also helps them to calm down, and then they are snug and cozy when they go to bed. So most young children are given a bath at bedtime, or they take a bath at bedtime. So go to toilet, take a bath, put on PJs, watch one show or read story, have milk. Again, go to toilet because a lot of children with special need have difficulties controlling their bladder or expressing the need to go to the toilet. Wash hands, brush teeth, go to sleep. Now, what this is an example of is that this kind of a routine is established, and we as a team or a multidisciplinary team is supporting the child to establish this routine. So this routine is broken into little steps, and this, a picture of this routine could be on the refrigerator or could be in the child's room or bedroom or wherever, or maybe in the bathroom. And every time the child does one of this, he can put a little laminated sticker, which shows that picture, into a box. So the child has a sense of achievement that I've completed this, now I need to do this, completed that. So end of it, I've ticked all of them, I'm now ready for bed. So it establishes a routine for the child. So this is how we will break one simple goal of having a bedtime routine into small little steps and give child a star when the child completes all of them. without needing too much help, too much support. So, and again, this is a bedtime routine is huge for the parents as well, because end of the day, parents also want the child to now settle in, go to bed. So it helps. So this is just one example, but there are various other stuff that can be done. Thank you. Next slide, please. So let's now look into what does an occupational therapist do in a multidisciplinary team approach. Again, as I'm talking about each person in a team, it gives you a kind of a glimpse or an idea about how the developmental goals are being supported by a team. Next one. I somehow can't see the top of the slide. Maybe it is. Okay. Yeah, that's better. That's better. So the occupational therapist would be doing the similar stuff like fine motor and gross motor skill activities, learning abilities including reading, writing, spelling, fine motor and pre-writing skills, sequencing skills. I'll give you an example of sequencing skills. So it is very important for a child to understand in any given action. For example, let's say make a sandwich, eat a sandwich. So what happens first, or what happens next, and what happens last? So sequencing or organization of any given thing that we take, like, adults take, like, we know what to do. But for children, they need to know what comes first, what comes next, what comes last. So sequence of an activity is really important in understanding how things work, problem solve, etc. So if you give 3 pictures to the child and ask them to kind of organize it according to the sequence, and I'm sure when you work with preschool children, you do a lot of those sequencing activity, what comes first, what comes next, what comes last. So the occupational therapist would be using or doing activities for sequencing skills. Sleep issues, again, as I just said, that children with special needs do have issues with falling asleep, going to bed. They have nightmares, night terrors. They want mother or father to be in the room. So the occupational therapist will actually go and visit the child at the time the child goes to bed, which here in Western countries, in New Zealand, it's generally 7 o'clock, 7:30. Children are generally in bed, younger children. So it's not like 10 o'clock. So, but still, it's the evening time. The occupational therapist will visit home, see the routine, and then formulate a plan so that the child is supported to develop a sleep routine. Because sleep routine is very, very important. If the child is sleeping well, he is more energetic, more active, more attentive, and able to participate in the activities in school or daycare next day. And it's also important for parents that the child settles in well. Personal care skills, including toileting, dressing, showering, eating and drinking, etc. Social skills such as turn taking, understanding emotions, participation in play. So these are some of the activities OT or occupational therapists would be doing. Independent living skills, for example, cooking, cleaning, work skills. You might be wondering where this is coming from. Now, this multidisciplinary team approach that we are talking about supporting children with developmental goals is meant for children up to 16 years of age. So by the time they are preteen or teen, they should know how to make a sandwich. For example, for you make instant noodles, clean their own room, and they might be working, doing some chores at home or outside. So those skills are also something that we would focus on. Next slide, please. Now, this is something very, very specific to occupational therapists, equipment prescription. So occupational therapists, by their profession, are trained. They are trained professional to know how to prescribe equipment for mobility, like walking and standing. So they know what particular kind of transfer chairs, buggies, would be suitable for a particular child, because it's not one buggy will or one wheelchair will suit all the children. So adjusting and ordering the right equipment. Also for toileting, showering, bathing, eating and sleeping, there are a lot of equipment that could help the child, like special toilet seat, handrails at the shower for bathing, little children, special kind of, bathtubs for eating and sleeping, special forks, etc., are there for helping the child to learn how to eat independently. So the occupational therapist is actually the person who has the expertise in understanding if equipment, prescribe equipment, order equipment, adjust equipment, and explain to the parents how to use the equipment. Also sensory processing and regulation, because a lot of children with special needs will have difficulties with processing stimulus, and that is sensory processing, whether it's auditory, visual, etc. So they develop a sensory profile and activities for calming and sensory regulations. And if you have worked with children with special needs, you would understand what the importance of calming and sensory regulation activities, because they can get overwhelmed with sensory stimulation that's happening in the environment or even their own bodies all the time. Then emotional regulations, managing big emotions, anger and anxiety, which is also quite often seen as kind of a need for children with special needs. Thanks. Next one, please. So this is an example, since we're talking about sensory regulation, I thought I'll show you this as an example or a picture of a sensory room. So you can see a ball pit, and you can see, I don't think you can see a trampoline. It will generally have trampoline. It will have those, those colorful balancing kind of things on which the children would be able to walk. So they can walk, they're asked to walk on that. So balancing is a fun activity. There are lights which could be dimmed, which could be changed. Then there is auditory stimulus, etc. Next slide, please. So sensory rooms are fun, safe, and engaging environment for children to regulate their sensory system. We use the sensory rooms quite a bit for children. So they will have ball pit, crash mats, tunnels, climbing blocks, auditory input, lights, balance beams, so that you are kind of helping the child to walk with balance, or supporting the goal, developmental goal of achieving balance. So sensory rooms are useful for calming techniques, boosting energy, because you do things that would calm you down, movement or vestibular input, attention and focus, stimulation, sensitization and desensitization, kinesthetic touch. One example I'll give you here quickly is we use what we call weighted blankets for some of the children for sensory regulation. So these are blankets which has weight inside it. So it's a cozy blanket, but it weighs down on the child. It helps them to sleep. It helps them to be comforted. So that's an example. You can Google search weighted blankets and understand what they are. They're very, very useful for children who have sensory regulation difficulties. Then auditory stimulation, that is calm music, etc. Visual stimulus, so the light could be dimmed, light could be changed depending on specific needs of the child. And sensory rooms are also useful for proprioceptive work. So proprioception or proprioception is part of supporting child's developmental goals, because it is proprioception is your body's ability to sense movement, action, and location. That is, your body should be able to sense your own movement, where you are, and where my hand or my leg or my head is going. So those kind of things, a lot of time with children with trauma, injury, cerebral palsies, etc. Proprioception work is important. And sensory rooms are also for therapy breaks. That is, it's a break from the therapy, go do fun things, and children look forward to going to sensory rooms, therefore. Next slide, please. Next slide, please. Thank you.
Just a second, Mom.
Cool. Here we are. So the next person in the team we are talking about is physiotherapist. Next slide, please. So physiotherapist, generally, you would think that physiotherapy is for older people, adults, and physiotherapy is when somebody has injured themselves or hurt themselves. So children with special needs have a lot of such needs. So the physiotherapist would use assessment tools for children with difficulties with coordination, balance, walking and running, or other gross motor difficulties. So what a physio does or a physiotherapist does in the team for supporting a child with special need is input for strengthening, that is strengthen the muscles, strengthen the range, movement, hands, legs, arms, the body. Exercises, provide an exercise to children. They actually work alongside the child. Provide adaptive equipment that could help strengthening, motor learning and play, as well as education. So physiotherapists would educate the parent about how to kind of improve the coordination, balance, or walking and running kind of difficulties the child might have. Next slide, thank you. So just a bit of brief idea about what are the contributing factors to delayed or poor quality motor development, to understand why we are talking about it, or where the physio comes in, what the role of physio is. So children with special needs or any kind of trauma, injury, etc., often will have low muscle tone and strength and endurance. They will have poor or underdeveloped coordination and balance, which you possibly have observed. They also sometimes have less than ideal body joint mechanisms or alignments. Their hands and legs may not be really well aligned. They will have sensory challenges like vestibular challenges. And sometimes they've had an injury. So in the MDT approach that we use with children, a lot of children have had musculoskeletal, that is broken bones, broken hand or leg or something, cerebral neurological symptoms. And these would generally follow TBI, which is traumatic brain injury. So traumatic brain injury can, kind of cause major deficits in motor development. And that is where the physiotherapist comes in. Thank you. Next slide, please. Speech language therapists, we call them speechies. They are really important part of learning and addressing the language difficulties. So what does a speech language therapist does? They are actually trained people in specific to be the speech language therapist. They assess child's communication difficulties through play and other therapy activities. They help the child to work on speech sounds, articulation, fluency, first words. Simple example I'll give you, like if a child is finding it difficult to produce the sound k. So if you you can try it yourself. If you hold your tongue down, it is easier to produce the sound k. And if you're doing the ta, the tongue goes up. So a speech language therapist has the knowledge of, what you can do with your mouth, your tongue to bring out a particular sound. And so that's how they help with speech sounds, articulation, etc. Speech language therapy. I think we are going all right with time, right?
Yes, Kanika, you can continue.
Okay.
It's so interesting.
So the language difficulties, including expressing and understanding language. And as you know, understanding or expression of language is so directly related to cognition. So your language skills impact on your cognition and therefore communication as well, which would involve memory, attention, perception, organization, request, that is able to ask a question, ask for glass of water, problem solving. So these are all kind of included in under the language skill, which is a huge part of cognition for any one of us. And speech language therapists, we call them speechies here. So they are most of the time involved in the multidisciplinary team And also feeding difficulties, you might find it a bit unusual. So children with eating, drinking, swallowing, chewing, or gagging, or refusing to eat, these kind of difficulties are addressed by speech language therapists because they know how the mouth and the vocal cords and this upper thoracic work. So they would help the children develop, those kind of skills and work with children on feeding help as well. So they are generally a major part of most of the MDT team for children with special needs. Thank you. Next one, please. Last but not the least, psychologists. Again, I'm just going to repeat myself that all the therapy or the multidisciplinary team listed here on my slides, there is no sequence as such in terms of hierarchy. They are all important, they are all equal, more or less, and there's nothing who is more important than the other. So psychologist, as you know, the kind of support a psychologist generally provides for children with special needs, they will work with children on developmental difficulties, social skills. A lot of children with special needs need to be supported to develop social skills, self-esteem, anxiety, and stress. And you can understand a child with special needs. Picture a child with special needs who has speech difficulties or is in a wheelchair, what impact it might have on the child's self-esteem, being bullied in school or being seen as somebody different. So the self-esteem, anxiety of being in a social, being in a peer group where everybody is different. Think of a child in a wheelchair in a preschool, everybody is running around, and the child in a wheelchair, even if it's an electric wheelchair, the child is not running. So how it impacts on child self-esteem and anxiety and stress that comes with it. It's something the psychologist would be supporting with. Time management and organization, which is again very important. Simple things like even getting dressed in the morning, getting up on time every morning. Attention deficit and hyperactivity. So that's a whole different area altogether. So psychologists do work with ADHD, specific ADHD and ASD, that is autism spectrum disorder, because they do have attention deficit and hyperactivity kind of difficulties. Behavior modification, which is how behavior could be modified again by breaking the behavior into small little steps, and then you completely modify a behavior that the parent or the for developmental goals of the child needs to be changed. Emotional regulation, that is, they can get angry, stressed, cry, and those kind of things. How you regulate your emotion, how not get overwhelmed. Conduct disorders, trauma, attachment. Attachment could work both ways, that some of the children with special needs would have attachment issues or difficulties. So attachment could be that they are too attached to their parent or caregiver and can't let mom go, can't let father go, and would need to be with somebody from the family, or they will find it difficult to form attachment. So therefore, again, how to form attachment, how to kind of be separated from the parent or the caregiver in a new environment and not to feel overwhelmed in a new environment. Cognition, that is basically understanding, learning, and everything that comes with it. Play therapy, so most of the psychologists work in clinics. Generally, they see children in the clinics and sometimes at home as well. And I'm sure you would be studying about play therapy in your child development coursework. So play therapy is one of the most common therapy most psychologists would be using when they are working with children. And the psychologist support the developmental needs or the goals of children with special needs. The support also includes parents. So parenting skills and parenting counseling is part of the role of a psychologist, because it's not easy bringing up a child, and when you have a child with special needs, your parenting skills are challenged every day, at every moment. So therefore, how to get those parenting skills, strategies to kind of manage children, and parenting counseling, because it's also stressful, emotionally stressful, causes a lot of stress and anxiety for parents to parent a child with special needs. So psychology support for that. And the last slide, please. Thank you. So here is summing up. Basically, I'll go back to where I started, that the physical, cognitive, emotional, and social development are interwoven. So the development does not take place in compartment or are not siloed. So they kind of interact with each other. They're integrated and interwoven and have a combined kind of, effect on child as the child is growing up. So when planning and implementing a multidisciplinary team approach, it is important to utilize the resources carefully. So whether it is funded by government, private funding, wherever the money is coming from, we have to be very, very careful about using the resources of these specialists. And a collaborative approach is essential. That is, everyone on the team is on the same page for supporting the developmental goals. So thank you very much for having me and listening to me. I am not sure whether there's time for Q&A, but...
Yeah, thank you so much, Kanika, for this very, very informative and enriching session, because we do early intervention in the class, and you summed up IEPs and family support so beautifully. I will apologize to the audience regarding the Q&A, because we are getting calls from the college. They unfortunately, they need the link for the next session.
Yeah,
so
sure thing.
Please put your questions in the chat box. I'll mail it to Dr. Kanika Naug, and I'm sure she will be happy to answer them. And I will request Prerna to, propose the official vote of thanks.
Amy, can I just say one thing?
Yes, please.
Kanika, I don't think you remember me. Vinita Bhargav here. Congratulations.
I do.
It's so wonderful to see you. And
thank you.
You did a great job, and I'm sure we'll connect with you at some later time. Thanks, Nimi.
Thank you so much for
your
presence.
Since she is part of the department, I thought it's important to, and we haven't connected with her for a long time.
I would have loved more questions too, but we are kind of constrained today.
Congratulate her.
Thank you so much.
Hello, Kanika. It was wonderful listening to you. And
thank you, Rekha.
And how are you? It was
I'm good. Congratulations.
Okay, thank you.
Rekha, I will pass on her contact number to you so that you can keep in touch. Sorry about this, Kanika. This is something which happened very suddenly.
I think I kind of over.
No, you didn't. You were absolutely on the dot, but the constraints are at our end. So, Prerna, will you please propose the vote of thanks? I don't want to miss out on that.
So on behalf of the department, I would like to thank Dr. Kanika Naug for this session. It was a very informative session, and I'm very sure that all the participants would have loved the session, very informative one. Thank you so much for taking out your time and doing this session for us. Thank you so much, ma'am. And
you're very welcome.
And I also want to thank Professor Swati Pal for always supporting us in various initiatives. Just a small request I want to make quickly. We can't take question answers, but can we take a photograph?
Yes, one group photograph. Yes.
So that
everybody, please unmute your camera so that we can take
a photograph with
quickly here.
Yeah.
Thank you so much. And please send your questions to us. I will personally mail it to Kanika.
Meanwhile, we are taking the photographs. I would also request all of you to fill the feedback form. It is very, very mandatory for us to have all the participants fill the attendance form. So I request
it was an amazing session. Amazing session.
We'll chat. Thank you so much.
Maybe we can do one more with you, for
I
bit of
support that.
discussion and
Yes.
interaction. Yes,
Yes,
we need it.
definitely.
Okay.
It was wonderful, really very nice.
Thank you, everybody. Thanks, Kanika, for doing it on a
Thank you.
working day after your work is over. Like you.
No worries. Thank you very much.
Thank you so much.
been a
So
pleasure.
lovely to connect with you again. Thank you,
Yeah,
everyone, and
pleasure.
bye-bye. Take care. Stay safe, everyone.
Bye.
Bye.
Take care.
Thank you,
See you,
ma'am.
bye.
Thank you.
Thank
Okay,
you,
bye-bye.
Swati. Thank you, Amita.
Bye.
Thank you, everybody from the HDFT
Thank you.
department
Thank
and other
you. Bye-bye.
participants and faculty members from other colleges who have joined in. And thank you, Professor Bhargav, for joining in again. And wonderful to have you all in this session. And bye-bye. I'm handing the link over to the college. Bye.
Bye.
Thank you, everyone.
Bye, Kanika.
Thank you, ma'am. Thank you.
Thank you.
And